So the previous review of the previous webinars is in webinar 1, we discussed different aspects of HIV disease, including definition, disease progression, stages, symptoms, and transmission modes in general and specific to Pakistan. We also discussed myths and facts related to HIV disease in general and specific to Pakistan. In webinar 2, our guest speaker, Dr. Philip Chan, discussed standards for HIV testing in general and in resource-limited settings, required lab testing for disease management, and standard precautions related to HIV lab procedures. In webinar 3, our guest speaker, Dr. Joseph Garland, discussed HIV care cascade, including HIV diagnosis, treatment, and retention, and presented Mariam Immunology Center clinic setting and routines. In webinar 4, our guest speakers, Dr. Susan Kuyuvan, Dr. Jerome Larkin, and Dr. Sabrina Holland, talked about preventing mother-to-child HIV transmission and taking care of infected infants and children. Last half an hour in every webinar is dedicated to discussion on the importance of open communications between healthcare providers and patients about the HIV disease, but it depends on question answer session and time left. So our objectives today are to learn about HIV-TB treatment practices, HIV-HEP-C treatment practices, and HIV-HEP-B treatment. So our first speaker is Dr. Martha Santos. She is an MD and internal medicine and infectious diseases faculty member at the Alpert Medical School of Brown University. She graduated from INTEC in the Dominican Republic, completed her residency in internal medicine at Mount Sinai School of Medicine, and a fellowship in infectious diseases at the University of Medicine and Dentistry of New Jersey. She is an attending physician at many hospitals in Rhode Island, including Mariam Hospital, Newport Hospital, and Rhode Island Hospital. Her research interests include HIV care continuum, global health, and tropical medicine. Our second guest speaker today is Dr. Natasha Ryback. She, I think, will introduce her after Martha's presentation. So I am presenting to you Dr. Martha.
Hello, my name is Martha Sanchez, Dr. Galanis, and thank you so much for the opportunity and for the generous introduction. So we'll be talking today about HIV and hepatitis, specifically hepatitis B and hepatitis C. To provide some epidemiology, hepatitis B and hepatitis C are of significant concern on patients with HIV infection because they share modes of transmission, and we will talk about that a bit further. Hepatitis C affects 2 to 5% of people living with HIV worldwide and up to 90% of those who inject drugs. Chronic hepatitis B infection affects about 5 to 20% of patients living with HIV, and it is the leading cause of liver disease in patients with HIV. Hepatitis B and hepatitis C are well-known causes of non-AIDS related deaths, so independent risk factors for deaths in this population. Talking a bit more specifically regarding HIV and hepatitis B infection. Hepatitis B, to provide some context, is an enveloped double-stranded DNA virus, and that will definitely be an implication in terms of the possibility of eradicating this virus and it causing a chronic infection. Hepatitis B causes 240 million cases worldwide, and it has a higher prevalence in countries such as Africa and Asia. The progression towards chronic liver disease, cirrhosis, and hepatocellular carcinoma can happen particularly in HIV patients, and unfortunately it can cause 25% of premature deaths. The good thing about hepatitis B is that it is preventable through vaccination, which is crucially important. Other forms of transmission for hepatitis B is through contaminated body fluid, which can be through injection drug use, needle exposure, and this needle exposure includes sharing needles, syringes, unregulated tattooing with used needles, body piercings, acupuncture, also hemodialysis because of sharing contaminated products, sexual exposure, sharing items where there might be microscopic exposure of blood, such as toothbrushes, razors, medical equipment, such as glucose monitoring devices, and this raises a concern of hepatitis B infection on diabetic patients that use these devices to monitor their glucose. Another form which is quite important is mother-to-child transmission. Ways where how hepatitis B is not transmitted is through sharing utensils for food, saliva, tears. These forms do not transmit hepatitis B. The clinical manifestations of hepatitis B will vary, and the time of incubation after somebody has been exposed to the infection is about 90 days, but this will vary from 60 to 150 days. About 70% of patients can be asymptomatic, meaning that they have no symptoms at all. If symptoms do occur, some of them can be pain in the right upper quadrant, nausea, vomiting, fever, arthralgias or joint pains, jaundice, which includes darkening of the sclera of the eyes and dark color of the urine. Some clinical findings are elevation of the liver enzymes, such as the alanine aminotransferase and the aspartate aminotransferase. And of this, we know that particularly the ALT, which is the alanine aminotransferase, is much higher than the AST, which is something particular for all virus hepatitis. 15 to 40% of patients with hepatitis C will develop cirrhosis, and at that stage they can progress to hepatocellular carcinoma and liver failure. So this virus, particularly compared with hepatitis C, has the capacity of causing hepatocellular carcinoma and is what we call an oncogenic virus. For the diagnosis of hepatitis B, so the recommendation is that all patients that are infected with HIV have to be checked also for hepatitis B. And this will happen at the time of diagnosis and depending on the risk factors. And I will talk about that in moving forward. How are we going to establish a diagnosis? We need to do a few blood tests. One of these will include the hepatitis B surface antigen, the total hepatitis B core antibody, the hepatitis B surface antibody. And I will speak moving forward about how we're going to interpret the results of these tests. The diagnosis of chronic hepatitis B is made the same way in HIV patients as compared to patients that do not have HIV. So the fact that they have HIV does not change the way that we diagnose hepatitis B. The risk of progressing to chronic hepatitis B, meaning that the patient will end up having potentially liver cirrhosis and hepatocellular carcinoma, varies depending on the age. So unfortunately, 90% among those that are infected before the 1 year of age can progress to chronic hepatitis. 25 to 50% of those that are infected from the ages of 1 to 5 years of age, and less than 5% among those that are infected as adults. This graph will give us some guidance of how we're going to interpret the tests that I mentioned earlier. Okay, so this is the hepatitis B surface antigen. This is the hepatitis B surface antibody, and this is the hepatitis B total core antibody that I had mentioned earlier that will help us diagnose somebody of hepatitis B. When all of the 3 tests that we do come back negative, that means that the person is not protected against hepatitis B, but also has not been exposed to hepatitis B. In this case, the main thing is to provide the person with the vaccine for the hepatitis B, and we'll talk about that more. After somebody receives the vaccine for hepatitis B, we need to check a month later to confirm that they develop immunity against that vaccine. And we will be measuring the levels of the antibodies. If it's more than 10, we consider the patient immune. If it's less than 10, this person needs to be revaccinated, and I'll be talking about that further. Another scenario would be if the surface antigen is negative, the total core antibody is negative, the surface antibody is positive. This means that the person is immune to hepatitis B through vaccination. When the surface antigen, and this is key, is positive and the core antibody is positive, but the surface antibody is negative, this means that the person has a chronic hepatitis B infection. But to specifically determine that somebody has chronic hepatitis B, we have to repeat these tests 6 months later. And if repeated at that time, the person continues to have the surface antigen, that means that the person has chronic hepatitis B. And so to have a better idea of the stage of this person and the degree of disease, we need to do other tests, which will include liver enzymes, hepatitis B E antigen that will tell us about how the virus is replicating, the hepatitis E antibody, the hepatitis B DNA. And the hepatitis B DNA is the test that is going to tell us how much of this virus is present in our blood. These patients with chronic hepatitis B, and I will talk about this in the future, will need therapy, particularly when they're co-infected with HIV. They will need liver fibrosis staging, and they will need screening for hepatocellular carcinoma. Another scenario is when the hepatitis B surface antigen is negative, the hepatitis B core antibody total is positive, and the surface antibody is positive. This means, so the core antibody tells us that the person has been exposed to the virus, but the presence of the surface antibody is telling us that the person is immune now to the hepatitis B. And the last scenario is when somebody has the surface antigen, they do not have a surface antibody. So this means that, again, they have the core antibody positive, telling us that they have been exposed to the hepatitis B virus, but they do not have the surface antigen, meaning that they don't have a chronic infection, but they also don't have a surface antibody, telling us that they are not immune. So they're sort of in limbo. So these patients, we recommend to provide them with a single dose of the hepatitis B vaccine and then to recheck 4 weeks later to assess if they have developed immunity, or if they don't, then it's recommended to provide a complete series of the hepatitis B vaccine. Treatment considerations for hepatitis B in HIV patients. So all as part of the backbone of the treatment for HIV, and I believe Dr. Garland mentioned earlier about the different treatment regimens for HIV patients. It is important that those that are infected with hepatitis B as well, that have chronic infection, have a regimen that is based on tenofovir. And there are different forms of tenofovir. There's the tenofovir disoproxil fumarate or the tenofovir alafenamide-based regimen. And this is regardless of the person's CD4 count or their hepatitis B DNA level in the blood. As you know, there are other HIV medications that have medications such as lamivudine and emtricitabine that have activity against hepatitis B, but they should be avoided to treat somebody by itself with HIV and hepatitis B, because there is a very high risk of developing resistance to that hepatitis B drug. So tenofovir is the key drug that these patients need to be on. Patients receiving antiretroviral therapy should continue hepatitis B therapy indefinitely, because if you stop the treatment for hepatitis B, then these patients can have a flare-up in about 30% of the cases, meaning that their liver enzymes go up and they can potentially progress to liver failure. Medications such as tenofovir, entecavir, lamivudine, emtricitabine, and tolivudine that have activity against hepatitis B should never be used alone on a patient with HIV in the absence of fully suppressive HIV regimen, because then we are not treating the HIV and we're just giving monotherapy for HIV, and then the HIV will develop resistance mutation. So it is important that there is that combination of treating the hepatitis B and the HIV appropriately, so that we don't develop resistance to hepatitis B and we don't develop resistance to the HIV. If the tenofovir cannot be used because the person has a contraindication due to renal disease, then an alternative would be to use a medication called entecavir that is very effective against hepatitis B and can be dosed on patients with renal disease. On patients that refuse to take medications for HIV, meaning that we would be only treating the hepatitis B, then the only alternative would be to use pegylated interferon 2 alpha. But at this stage, because of the complexity, it would be important to have the assistance of an infectious disease or liver specialist, a gastroenterologist. Monitoring of these patients, very important to check their liver enzymes every 3 to 6 months, to monitor their renal function, again, because tenofovir is cleared by the kidney, and so we need to make sure that there's no toxicity or we don't need to do any adjustment, and the virologic response. And a primary non-response would be somebody that has a hepatitis B DNA of less than 1 log drop decline at 12 weeks. A complete virologic response is somebody that is undetectable for hepatitis B DNA at 24 to 48 weeks. And a partial response would be somebody that has a decline but still detectable DNA at 24 weeks. In terms of assessing the degree of liver fibrosis, which is very important on this patient. So we know that stage 0 is when somebody has no fibrosis in their liver, and stage 4 is when patients have liver cirrhosis. We have ways to make calculations, and I'll mention some moving forward, to estimate the degree of liver cirrhosis. Other methods would be to do an elastography, but sometimes this can be costly. And liver biopsy is rarely necessary and should be individualized for its necessity. Liver ultrasound is very important in this patient to assess for liver fibrosis, but we might only be able to see it when the person already has cirrhosis. But it's very important to assess for hepatocellular carcinoma. So we're going to be assessing if there's a presence of any mass. And for patients that do not have liver cirrhosis, it may be done every 12 months. For patients that do have liver cirrhosis, it should be every 6 months. And these patients should be counseled about avoiding alcohol abuse. How to prevent hepatitis B? So this is the key point. Being that it is a disease that can be prevented, we have a very good vaccine for it. And so all patients with HIV infections who are susceptible to hepatitis B should receive the hepatitis B vaccine. This is a 3-dose vaccine that is given at moment 0, which is when we have the patient in front of us, 1 month later, and 6 months later. To assess that the person is immune and has that the vaccine has been effective, we check the hepatitis B surface antibody 4 weeks after the last dose of the vaccine. For those who do not respond to the first series, there are a few alternatives. One would be to repeat the vaccination series at the same frequency at a double dose, meaning that we're going to be giving them 2 injections of the same vaccine, which is a total of 40 micrograms. Another option would be to give a 4-dose series at time 0, 1, 2, and 6 months, either at a standard dose of the 20 micrograms or the double dose. Or repeating the vaccination until the person has a CD4 of higher than 200 to 350, but at the same time, we do not want to delay vaccination because the person might be at risk in the meantime that we're waiting for the CD4 to increase. For patients that do have hepatitis B, then it is important to assess all family members and sexual contacts for hepatitis B infection, and if they're not immune, they need to be vaccinated. Now we're going to switch to hepatitis C infection and its co-infection with HIV. Hepatitis C is different from hepatitis B in that it is a single-stranded RNA virus. It has a worldwide prevalence of 2 to 3%. The co-infection with HIV more than triples the risk of liver disease, liver failure, and liver-related death. It is curable, but we do not have a vaccine for hepatitis C. The time for CD4 recovery is impaired on these patients, and so we might see that the CD4 doesn't increase as quickly on them after we have started effective antiretroviral therapy. It is 10 times more infectious than HIV through percutaneous blood exposure, and it has been shown to survive weeks in syringes. Forms of transmission include mother-to-child transmission when mothers are infected with HIV, and in them the risk is 10 to 20%. Sexual intercourse, particularly men having sex with men. Healthcare exposure, including hemodialysis, needle stick, blood transfusion of contaminated blood. And so again, because of the exposure to contaminated blood, we also have to counsel our patients about exposure, as with hepatitis B, with toothbrushes, razors, anything that can have microscopic exposure of blood. Intravenous or intranasal drug use, and incarcerated patients. Again, same as for hepatitis B, this is not transmitted by saliva or tears or sharing utensils for eating. Or sharing towels. Yeah, it has to be blood with blood. Clinical manifestations of hepatitis C, 20% with acute infection have characteristic symptoms, so a lot of patients do not have any symptoms at all. Unfortunately, 60 to 80% of patients will progress to have a chronic infection, and of these, 30% will progress to liver cirrhosis, and this may take about 20 to 30 years, depending on other co-infections, alcohol abuse, and other liver comorbidities. Signs and symptoms are similar to hepatitis B, so low-grade fever, mild right upper quadrant pain, nausea, vomiting, anorexia, dark urine, jaundice, elevation of the liver enzymes, so the alanine aminotransferase and the aspartate aminotransferase. These patients can also have complications with other systemic manifestations, such as symptomatic vasculitis due to cryoglobulinemia that can affect the skin, renal disease, so it may cause a type of glomerulonephritis, and may also cause porphyria cutanea tarda. To make the diagnosis of hepatitis C, all patients that are infected with HIV have to be checked for hepatitis C. There is an immunoassay for detection of the antibody of hepatitis C in the blood. For patients that have a hepatitis C antibody, meaning that they have been exposed, we should be checking a hepatitis C RNA level that will tell us if this virus is replicating. This will differentiate if the person has a chronic infection or if they have cleared the disease by themselves. So when we have somebody that has a negative hepatitis C RNA level, but they have a hepatitis C antibody positive, it means that they were exposed to hepatitis C, but they have cleared the disease. And once somebody has an antibody positive for hepatitis C, even if they have been treated, this will remain positive because it is only telling us that the person has been exposed to hepatitis C. Another test that we need to do is the hepatitis C genotype, and it will tell us the different subtypes of hepatitis C. And these are 1 through 6, and it varies depending on the location of the world. Renal function is very important because it will guide us of what medication we'll be using. And because, again, hepatitis C can affect the liver, the kidneys, and it's also important to assess liver fibrosis. And we have, again, different ways to calculate this. One of them is the APRI score, which is the aspartate platelet ratio index. And I will be showing you the formula for this, and the FIB4 test, which is a blood test that can check different markers that can help us estimate the degree of fibrosis in the liver. Following acute hepatitis C infection, there is a window period before the person actually develops the antibody against hepatitis C, and this can range from 2 to 12 weeks. So these are the two calculations that you all can use to estimate the degree of liver fibrosis. And again, this can be used for patients with both hepatitis B and hepatitis C. They can okay. So this is something that in this website that you can see underneath, you can actually go to this web page from the University of Washington, and you put in the information about their AST, their platelets. We can have an estimation of the degree of the fibrosis, same as for this other calculation, which is the fibrosis 4 calculation. It takes into account the person's age, their AST liver enzyme, and their platelet, and their ALT liver enzyme. So as described here, it can help us, again, estimate if the person has a low degree of fibrosis or a higher degree of fibrosis, or if they potentially have liver cirrhosis, as this will be important at the time of treating the patient, and to know how often we need to screen them for hepatocellular carcinoma. This is a map of the world that tells us about the different genotypes and how common they are in different parts of the world. For example, in Asia, we see that there's a higher prevalence of genotype 3, followed by genotype 1. But the good thing is that we have medications that treat for all the different genotypes. When treating somebody that has HIV and hepatitis C, it is very important to take into account the drug-drug interactions with the HIV medications. Some of the HIV medications that are known to have a higher potential of causing interactions with hepatitis C medications are efavirenz, atazanavir, ritonavir, darunavir, ritonavir, but it should be checked on a case by case. So every time that we're going to treat a patient and that we have a selected and available hepatitis C regimen, we should do an assessment at that point of the drug interactions to assess if the person potentially needs a change in their HIV regimen in order to safely treat their hepatitis C. There are, and these recommendations are based on the 2018 WHO guidelines that you can access, and I will provide the address at the end for references. So there are pangenotypic regimens, meaning that there are medications that treat different genotypes of hepatitis C. And for patients that are 18 and older that do not have liver cirrhosis, options are sofosbuvir velpatasvir for 12 weeks, sofosbuvir daclazavir for 12 weeks, or glecaprevir piventrosvir for 8 weeks. And this is okay to be used on patients with renal disease as well. For adolescents that are aged 12 to 17, that or adults that weigh less than 35 pounds, the WHO 35 kilos. The options are sofosbuvir ledipasvir for 12 weeks for patients that have genotype 1, 4, 5, and 6, sofosbuvir ribavirin for 12 weeks on those with genotype 2, and sofosbuvir ribavirin for 24 weeks in patients with genotype 3. So genotype 3 takes a little bit longer to be treated in order to be eradicated. Patients that are pregnant, they cannot use pegylated interferon and ribavirin, which would be another alternative for patients that, but this treatment is quite toxic. And again, at this point, it should be managed by an infectious disease specialist or a gastroenterologist. How to determine if somebody has cleared their hepatitis C? This is when they their hepatitis C RNA viral load is negative 12 weeks after they have been treated. And this is achieved in more than 90% of patients that are treated with these oral regimens. Patients with genotype 3 or those that have liver cirrhosis have unfortunately a lower chance than 90%, but still higher than 75%. After hepatitis C treatment, so we need to check again the hepatitis C viral load 12 weeks after the end of treatment to determine if they have cleared the infection. An important consideration is that persons that are co-infected with hepatitis B and hepatitis C, they are at risk of hepatitis B activating during and following hepatitis C treatment. But again, remember that the HIV medications also treat hepatitis B. And so it's even more important that they're on an effective regimen for hepatitis B. Detection of hepatocellular carcinoma in persons with liver cirrhosis should be every 6 months with an ultrasound of the liver, and alpha-fetoprotein is another marker that when elevated should raise suspicion for hepatocellular carcinoma. We should monitor for reinfections, because even though patients are treated with hepatitis C and they clear the infection, if they continue to have risk factors, they could be reinfected, and these patients have to be counseled about avoiding alcohol as well. So in conclusion, all HIV-infected patients should be screened for hepatitis A, B, and C. You all know that hepatitis A is transmitted through food, but it does not cause a chronic infection. It is self-cleared. We do have a vaccine available for hepatitis A, and so all patients that are susceptible should be vaccinated for hepatitis A and hepatitis B, but also confirm their immunity. Some HIV medications also treat hepatitis B. There is no vaccine for hepatitis C, but it can be cured. Check yearly for hepatitis C if the person continues to have risk factors. Counsel our patients for avoiding alcohol and other medications that can harm the liver. And patients with chronic hepatitis B and C need to be monitored for liver cirrhosis and hepatocellular carcinoma. Here are some references that are available online and free, so that everyone can access them, and they have most of the information that I provided to you today. Thank you so much for the opportunity, and I will be answering questions after the presentation by Dr. Ryback. Thank you.
Thank you very much, Dr. Santos. It was very good. Now we are moving towards our second guest speaker. She will be talking about HIV-TB co-infection. So after her talk, we will start the question session. So this is Dr. Natasha Ryback. She is an assistant professor of medicine on the Brown University Medical School faculty and is the medical director of the TB clinic. Her specialties are infectious diseases and pediatrics. She is an attending physician at Hasbro Children's Hospital, Rhode Island Hospital, the Mariam Hospital, and Newport Hospital here in Rhode Island. Dr. Ryback received her medical degree from the Warren Alpert Medical School of Brown University with Brown Dartmouth Medical Program. She completed her residency in combined medicine and pediatrics, followed by fellowship in combined adult and pediatric infectious diseases. Dr. Ryback's clinical and research interests are in global health, with a specific interest in TB, HIV and TB, and multi-drug resistance tuberculosis among adults and children in Eastern Europe. She helped to create the Brown University Ukraine Collaboration, a global health initiative program at Brown University. She helped to create the Brown University Ukraine Collaboration, a global health initiative program at Brown University to address the issues of TB, HIV co-infection, and MDR-TB in Ukraine. And here I present Dr. Ryback's presentation.
Hello, it's nice to join you all today. I'm going to talk about HIV and TB co-infection, and also with a concentration in pediatrics, because that's a very challenging field, and I know most of the patients are actually children in this group. So first I want to talk a little bit about the global burden of tuberculosis. I'm sure it's widely known, but by 2017, between 2017 and 2015, there was greater than 1 million new active TB cases in children and over 210 deaths. Of those, greater than 32,000 have multi-drug resistant tuberculosis, and we know that worldwide greater than 50 million children have TB infection, that is infection, not disease. So I think that this is a very helpful figure. This is a figure that shows the three, sorry. Thank you. So this is a figure that shows where TB is high burden in the world. In the center, there are TB high burden countries, and then on the left are MDR TB high burden countries, and on the right, TB and HIV high burden countries. Here you can see Pakistan is part of high burden TB and MDR TB. So just a little bit of TB in Pakistan, the rate is 267 per 100,000. So this is a high burden country. There is a low percent per WHO with known HIV status at around 7%. And multi-drug resistant TB estimates are 4% of new cases and about 16% of retreatment cases. As I start, I want to give a little information about resources to use. The WHO has excellent resources for both adults and children, but specifically for pediatric TB and HIV, I'd like to point to the child TB guidelines from the WHO. And for particularly difficult cases, I'd like to point to the Sentinel Project, which has pediatric management of MDR TB and has a lot of detailed resources that are very helpful for this difficult population. So this is the most recent second edition guidance for national TB programs for the management of tuberculosis in children. And this is an example of the Sentinel Project website, which has really important information for the management of MDR TB. And this includes MDR TB in children and with also HIV. These are very helpful resources. So to talk a little bit about MDR burden worldwide, this is a very nice schematic graph of the world from the WHO that shows where the highest prevalence of MDR is. So I want to talk a little bit about the burden of pediatric TB. So this can be very hard to figure out, and there's multiple reasons for this. So children who have tuberculosis are more likely to have extrapulmonary TB. This is because children, as well as adults with HIV, have something called paucibacillary disease. So this means that the amount of bacteria, of tuberculosis bacteria, is actually much lower. And so it's harder to identify their disease with a microbiological diagnosis. Children under the age of 5 will only have about 30% chance of having a microbiological diagnosis of TB, and this is less so in patients with HIV. Additionally, it is harder to get an adequate specimen on a patient who's a pediatric patient. These patients are also less likely to transmit to others, and so very often they are less likely to attract the attention of public health services in countries. To talk a little bit about TB pathology and diagnosis in children. So I'd like to talk a little bit about the risk by age. So in less than a year, children who are exposed to TB have up to a 40% chance of developing pulmonary disease and about a 10 to 20% chance of developing TB meningitis or miliary disease. Children between the ages of 1 and 2 years old have about a 10 to 20% chance of developing pulmonary disease and about a 5% chance of developing tuberculosis, meningitis, or miliary disease. This risk decreases up to the age of about 5, and then becomes similar after 5 to the adult population. I'd like to talk a little bit about the clinical presentations of TB in children. So pulmonary TB mostly is primary, not reactivation TB, which is different than we find in adults. Pediatric patients usually develop active disease after their initial infection if they're going to develop disease. There's uncomplicated disease is often unilateral adenopathy or cervical adenitis can be one sign. Most common would be primary TB complex. The primary TB complex often is associated with hilar or mediastinal adenopathy. Children can have very nonspecific symptoms. They may not even have cough yet, and sometimes they can have an associated lung opacity. Oops. Complicated TB can include lobar or more significant adenopathy. Sometimes this will cause a bronchial compression and cause a unilateral atelectasis. This is because the significant lymphadenopathy has actually occluded the bronchus and caused atelectasis. That can be a sign on chest x-ray that this child has tuberculosis. There can also be unilateral hyperinflation, which could be seen on a chest x-ray. It is rare for children, especially young children, to have cavitation. This is something that is more common in the adult type tuberculosis, which starts to take place at around adolescence. Kids can also have a bronchopneumonia. Very young children could have meningitis, disseminated TB. Another sign of pulmonary TB can actually be pleuritis or peritonitis as well. And rarely, but possible, children can also have spinal TB. The presentations of TB in children with HIV can be more unique and more challenging to diagnose. This often depends on the stage of HIV. In very early HIV infection, the presentation with TB can be similar to an HIV negative child. In late HIV infection, disseminated TB is much more common. Children can have meningitis, miliary disease, and also a TB adenopathy as well. Older children with TB and HIV often have similar presentation to HIV positive adults. HIV and TB co-infection have longer hospitalized stays, malnutrition, and a higher mortality. It is very important to have a high index of suspicion for TB in an HIV positive child. And although we can sometimes find isolates of M tuberculosis, it is much more difficult to get this microbiological diagnosis in children with HIV and H as well. So the diagnosis of TB and HIV infected children. So it's very important to know, and I'm sure as in Pakistan, many people have diagnosed these patients, but children do not often produce sputum, especially under the age of 5. Very often we have to use other modalities to collect specimens from children. Some of this includes gastric aspirates, which is usually accompanied by having a tube that goes through their nose or mouth and into their stomach, and having gastric washing or gastric aspirates. The other thing is sometimes nasopharyngeal lavage is also collected. Most important is a careful history of a chronic cough that is at least 2 weeks of age, 2 weeks going on. Fever is also helpful. Weight loss, failure to thrive. And failure to thrive in these children is actually the failure to gain weight. A child who is losing weight is already probably severely ill. Children should be continually growing, so if they're failing to grow, this is a sign that a child is not thriving. Another really important thing to note is contacts. Young children develop TB from contacts around them who have exposed them to TB. This is usually older household members, parents, caregivers, especially other HIV-infected adults. So it's very important to look at the environment. Clinical examination, in addition to the normal examination, you should look for a full exam that evaluates the spine, looking for any kind of abnormalities. Meningitis, so looking at a child's ability, making sure that they're able to walk and interact normally, have normal activity. An evaluation of the lungs and a lung exam, evaluation of the abdomen to make sure they don't have distension, to examine their whole body for lymph nodes, to evaluate the joints. The other thing that is useful is to look at the MAN2 or tuberculin skin test. In many children, the MAN2 will be positive with TB infection. However, it's important to note that children with HIV, that a negative MAN2 does not exclude active disease or exclude TB infection. Many children who've had HIV for some time and have a low immune system may have no response to a TST. So this test, although it can be helpful, does not exclude the possibility that a patient has TB infection or disease. And in high-risk contacts, any tuberculin skin test of greater than 5 millimeters should be suggestive of TB infection and exposure. The most important thing to think of for patients is to gather history, more history, and I like to say more and more history. For pediatric patients especially, as well as other adult patients with HIV, it is really important to listen to the patient and get this history, because there is a good chance that you will not be able to get a microbiological diagnosis to support the actual diagnosis of TB in an HIV patient. To give a little bit of information about the symptoms are often due to an immune response to very few organisms. The different clinical manifestations have varying incubation periods. Miliary disseminated disease can happen rapidly, especially in children. It can be as little as 1 month, faster maybe in HIV patients. And pulmonary and lymphatic involvement usually takes up to 4 to 12 months after exposure, but can be less also in HIV patients. For children, most clinical manifestations occur within 1 to 2 years of infection. It's important to remember that TB is a family disease. Children who have active TB likely have a very recent exposure. It's critical to look at the family and close contacts. So if you have a suspicion of a pediatric patient who has TB, the whole entire family should be evaluated. If they haven't been tested for HIV yet, they should be tested for HIV. If they have any symptoms, they should have chest x-rays or have a very careful physical exam looking for other sources of possible TB infection. By very good contact tracing and preventative treatments for other children and family members, you can prevent active TB in these other family members. To discuss some available tools for diagnosis, GeneXpert is our most valuable tool currently for diagnosing TB. It's used worldwide. Tests for the presence of Mycobacterium tuberculosis DNA and resistance to rifampin. If a patient has a positive GeneXpert test for TB and is noted to have resistance to rifampin, then the patient should go on a treatment regimen for multi-drug resistant tuberculosis. This is just to show the cartridge. It takes 1 hour and 45 minutes from raw sputum to detect a diagnosis of TB. This use is supported in children by the WHO and should be used in all ages, children and adults, as an initial diagnostic tool in those suspected of TB and or MDR-TB. All children suspected of TB disease, it does detect the majority of children with smear-positive TB, but remember, this is less than 30% of children. It can be used for sputum, gastric aspirate, nasopharyngeal lavage, also cerebral spinal fluid and tissue, per the WHO. To talk a little bit more about gastric lavage, in the US, we tend to do 3 consecutive aspirates. This may not be achievable in all settings, but basically a nasogastric tube can be placed in the evening if the patient is in a hospital or even in a clinic, and then can be collected in the early morning before the patient wakes up. It is also important that the lab processes the sample and adjusts the pH in order to maximize the recovery of any culture from this as well. A nasopharyngeal lavage, it can also be very helpful. This is usually nebulized saline and then aspiration of the contents. This is particularly helpful for young children, especially those less than 1 year. bacteriological confirmation. We try to get this in as many cases as possible. The reason why this is helpful in addition to the gene expert is that with a culture of Mycobacterium tuberculosis, we can find the drug resistance of other classes of antibiotics. And additionally, for patients who have severe and complicated cases, it helps with the treatment. Move on to next. Additionally, investigations for pulmonary and extrapulmonary TB. This is the case for not only children but adults. If someone has a pneumonia that's not getting better with persistent lung opacities, this is very highly suggestive of TB. Pleural effusions in patients with HIV should often be considered to be HIV unless proven otherwise. Any patient who has any CNS abnormalities, their CSF should be evaluated for TB meningitis. In general, patients can use CTs and MRIs and bronchoscopies, but these tools are not usually needed if you have a clinical thought that this patient could have tuberculosis. And to move on to treatment. Treatment is the same basic principles as treatment for adult patients. The idea is to treat disease effectively, prevent resistance. And it's very important to identify contacts, as this may be the only clue to drug resistance. TB treatment includes isoniazid, rifampin, ethambutol, and pyrazinamide for 2 months, followed by isoniazid and rifampin for 4 months for pulmonary TB. Keep in mind that rifampin interacts with antiretroviral regimens, and there are regimens that are recommended by the WHO that I'll go into shortly. Additionally, longer treatment durations are needed in patients with bone and joint disease, disseminated disease, and some forms of extrapulmonary disease. So here I'd like to go through, this is taken from the WHO, and this is very helpful. This is a summary of the recommended antiretroviral treatment regimens for children who are also co-managed with TB. The most important thing to know is that because rifampin interacts with some of the antiretrovirals, these are the recommended treatments. So for younger than 3 years, it is recommended to use 2 NRTIs and a dose of nevirapine that is equal to 200 milligrams per meter squared, which is you had to calculate out the body surface area, or to use a combination of AZT, 3TC, and abacavir, ABC. Additionally, for children that are 3 years and older, you can use an efavirenz regimen as well. This includes 2 NRTIs and efavirenz. These are for children who are starting ART while already on TB treatment. Additionally, recommended regimen for children and infants who are starting TB treatment while ARTs are on. This is a similar regimen, but you can actually also you can change to children who are greater than 3 and younger than 3 or 3 years old. You can also include a protease inhibitor and NRTIs, but it's important to know that the ritonavir should often be increased because this is a drug interaction between rifampin. So adding additional ritonavir. If this is unable to be achieved, it's better to potentially use a different regimen. The other important thing to know is that children with suspected pulmonary TB who are living in high settings of HIV or may have HIV-TB co-infection, they should not be treated with intermittent regimens. Intermittent regimens for both HIV, adults and children are not recommended due to the higher rates of development of resistant TB. The timing of antiretroviral treatment after anti-TB treatment is such. For both pulmonary and extrapulmonary TB, if the patient is not already on ARTs, then the patient should wait 2 to 8 weeks after TB treatment is initiated. If they have a low CD4 count, this should be closer to 2 weeks because these patients have severe advanced immune deficiency and their outcomes have a higher morbidity and mortality if they're not started on antiretroviral therapy sooner. This is most likely due to also other opportunistic infections. If patients are already started on antiretrovirals when they're diagnosed with TB, those antiretrovirals should be continued. Some special considerations include immune reconstitution, or IRIS as we know it. So this can be an exacerbation of symptoms. People can get severe lymphadenopathy, fevers. This is often part of their immune system responding to the TB, which was suppressed when their immune system was low. This can be managed with steroids and is often self-limited. Additionally, patients who have TB meningitis or miliary TB, sometimes with airway obstruction from significant hilar lymphadenopathy from TB, these patients can also benefit from steroids. This improves survival and reduces mortality, and these patients can have their dose tapered at around 4 weeks. It's very important to monitor patients during treatment, to look at their symptoms. Adherence, we encourage directly observed therapy if it's able to be done. Additionally, it's important to evaluate patients for liver function or hepatotoxicity, rashes. Sometimes some drugs may cause issues with their platelets or white count. Again, this is actually pretty rare for children and more common for adults. The most important thing for pediatric patients is to look at their weight and their adjustment of weight gain for their medication. We expect children to gain weight while they're on treatment, and their weight gain and their clinical is a very important clue to their clinical response to therapy. Additionally, if there is a positive microbiological specimen for TB, it's important to follow that so that you can determine if the patient has a response to therapy. The next thing I'd like to talk about is the prevention of TB disease in patients who are HIV infected. It is very important when a child is infected with HIV to then think about their risk of development of TB disease, and that can be mitigated by determining if they're infected with TB and then to prevent them from developing active disease with an INH preventative regimen. So children who are living with HIV for greater than 12 months and unlikely to have active TB on symptom screening should have at least 6 months of isoniazid preventative therapy. Okay. Additionally, children who are less than 12 months of age, only those who have contact with a TB case and are evaluated should receive 6 months of IPT if they have no TB disease. This is a very helpful algorithm here from the WHO. So WHO recommends screening and IPT in children over 12 months of age and living with HIV. So here's children of over 12 months of age and living with an HIV adult and also or having HIV themselves. So it's very important to screen for TB. It's important to look at the child's weight gain, to look at if the patient has any clinical symptoms of illness and their contact history with a TB case. If any of that is positive, then you need to investigate for TB disease. This can include a chest x-ray and a full exam. If there is no signs of active disease, then you should start this patient on INH preventative therapy. If this patient has TB, then they should be treated for TB. If a patient has, I can't think of so many, contraindications to IPT are rare. So in most cases, you're going to find patients who are either eligible for an isoniazid preventative therapy or being treated for TB. Just a summary of recommendations on when to start ART in children. In resource limited settings, all individuals that are children less than a year of age should be started on antiretrovirals regardless of their CD4 count. Between 1 year to 5 years, it is also recommended to treat all individuals. If you need to prioritize, then it can be WHO stage 3 or 4, but ideally it's best to treat all individuals. 5 years and above, only in resource limited settings would we recommend to treat only at stage 3 or 4. ideally all children should be treated with antiretrovirals. I want to talk a little bit about the challenges of treatment for TB and HIV. Very often, formulations are not widely available, and children are left to eat portions of pills that are made up of adult formulations. I am not sure the availability of these medications in Pakistan, but if they're not available, then there should be advocacy to help get these available. The TB Alliance collaboration has worked to create a dispersible scored tablet for first-line treatment for TB, for sensitive TB. This is available worldwide and eliminates incorrect doses, broken pills, and now allows children to have a fixed dose combination of sensitive TB treatment that's in a dispersible form that can be put into a small amount of water and become a drinkable, tasty way to take your medications. Because otherwise, HIV and TB treatment can be very challenging. And I want to say thank you, and then we can move on to questions.
Hi, this is Dr. Sumro from New York. I'm going to give a chance to Shahid Muhtarma Benazir Bhutto Medical University if they have any questions. Go ahead, please.
Dr. Aziz, I am pediatrician Dr. Shantilal from SMBBU Larkana.
Go ahead, please.
Thank you very much. Thank you very much for uploading us on HIV and co-infection in children. I'm more interested to know the patients who are coming to us with HIV positive, and on screening they are found to be positive for hepatitis B. But their synthetic function of liver like PT and the ALT is normal. So should we treat with ART plus hepatitis B regime, or just to follow ART and synthetic function of liver?
So the important is to, whenever we're going to treat HIV, to have a regimen that includes tenofovir, and this will also treat the hepatitis B, regardless of their stage. So we should never, when we have a child that has both HIV and hepatitis B, an HIV regimen that includes tenofovir, so that we're also treating the hepatitis B. And it should be regardless of their liver enzymes or if they have any liver damage or not.
How long we should continue this hepatitis B treatment when their liver functions and synthetic functions is normal?
So again, since these children or adults are also infected with HIV, it should be lifelong.
Lifelong.
Yes. So again, it's a matter of picking an HIV regimen that includes tenofovir, so that we are treating both the HIV and the hepatitis B. And HIV medications, once they're started, they should be continued long. And any interruption should be avoided, because as I mentioned earlier, it can cause a flare-up of the hepatitis B, and it can potentially cause progression of the hepatitis B and even liver failure.
Okay. Another cases we are now keep on observing is cases who are requiring frequent blood transfusion, like thalassemia patient. They are HIV positive, B positive, and C positive, and their serum iron load is very high, more than 3,000. So the treatment regime is same, or dose is varied from patient to patient?
And when you say elevated viral load, would this be of which one? The HIV, the hepatitis B, or the hepatitis C?
No. Apart from this, serum ferritin level is very high. Cases of thalassemia.
Okay. Okay. So somebody that has elevated iron in the level. Okay.
Yeah. Yes.
So the treatment for again, for hepatitis B would not change, being that, again, we're going to be treating the HIV as well. The treatment of hepatitis C would be based on the medications that I had mentioned earlier. Depending on their availability, I'm not sure how they are available, the oral regimens in Pakistan, and then the treatment for the iron overload should be treated separate by a hematologist. Yes, but definitely each individual one should be addressed, because since each individual one can cause liver cirrhosis, having all of them combined will cause significant acceleration of the time that the person actually develops liver cirrhosis.
Okay, thank you. Another question to the second speaker, Dr. Natasha. Is she here?
Yes.
Yes.
Yes. I'm a pediatrician, because most of the children who are coming to us with HIV positive, they are presented to us with complications like empyema, pleural effusion, collapse, consolidations, and extrapulmonary tuberculosis. Should we treat them ART with tuberculosis drugs, or should we manage them first with ATT and then we start ART? And for information to you, the disposable tablets are available in Pakistan, and we are currently using in SMBBU Larkana Children's Hospital.
So are you able to collect CD4 counts on these patients?
Oh, yes.
Okay.
Yes, CD count is frequently available.
Yes, I would recommend that you do, especially you should prioritize children who have CD4 counts or percentages less than 25% to receive ARTs within 2 to 8 weeks of therapy. If they are particularly low, I would recommend it around 2 weeks just after starting TB therapy. So TB therapy first, then ARTs. The lower the CD4 count, the sooner, more on the 2-week end. And then by 8 weeks, probably the majority of them. If someone has a very preserved CD4 count, it's possible that you could delay, but really probably it's best to start more towards the 8-week end.
Okay, the duration of anti-tuberculosis drugs remains same for pulmonary tuberculosis, or we can extend from 6 months to 9 months, those who are HIV positive.
So you don't have to extend the treatment. It should be more based on similar to what you would do if this patient had TB alone. So if this patient had TB alone and it was pulmonary disease, you would give 6 months. If they had disseminated disease or bone and joint disease, you would do 9 to 12 months. The only caveat with that is you do want to make sure that they have clinical improvement. And that if you do have a microbiological diagnosis, you want to see that you're having culture conversion.
One more question. Recently, we received a newborn baby. Her mother is positive for HIV, and she's on ART treatment. But the newborn baby who are severely infected with, I don't know which type of infection, we are treating them with sepsis. It is the manifestation of HIV to the mother and the presentation of the newborn baby, or how to manage. I was very puzzled to how to manage these babies. Mother positive HIV, delivered a baby. Babies are preterm low birth and presented with severe infection.
Are these babies HIV infected? Do you have
how to diagnose these newborn babies? Mother is positive for HIV.
Mm-hmm.
And
so that's a good question. So do you have any RNA testing for I guess it would be equivalent, you could do viral load testing
no, but that is not
for children? It's not available?
No.
Okay, so so viral load is not available. So you don't have any testing for babies?
But yes.
That's really tricky. Because there's a high possibility. So there's a high possibility that this child has HIV. So if you can't do a CD4 or viral load on the baby,
you see, the viral load is not available. They refuse CD count for these newborn babies. They are doing CD counts for the children, older one. and we were have a discussion, academic discussion. They said this baby is not suffering from HIV. Just treat as a sepsis.
No, so those children should really be prioritized because they have very high risk of death. And if this is a child who contracted HIV in pregnancy, then after birth they would have a very high mortality rate in the first year of life, in the first 6 months. So I think this is a patient who I would prioritize trying to get a viral load to get a diagnosis of HIV, and then should be started immediately on HIV treatment.
Full regime or single regime, that is nevapirin?
So they should be started on 3-drug treatment.
Okay.
Yeah.
So it is really recommended in the newborn baby who's preterm and low birth weight babies?
So yeah, the medicine will work. So the situation is that it would be so exposed babies often get nevirapine if they're just exposed, but in a baby who you don't know whether or not they have HIV, then this baby should be treated with 3 drugs because you don't want them to get resistance. And so if the baby is possibly infected, you want to make sure that they're treated with all 3 drugs as a 3-drug regimen, antiretroviral regimen.
Okay, thank you very much.
And that for advocacy, that would be a priority to be able to get testing for these babies.
I am Dr. Farooq Rahman Sumro from Ladkana, working on HIV in Ladkana. My one question, co-infection of the leishmaniasis in the HIV positive cases. How to treat the vector-borne disease leishmaniasis in HIV positive cases, especially adults?
Yeah. No, yeah. I mean, it would be just to make sure that there is no drug interaction with the HIV medication.
What drugs do you use usually for leishmaniasis in Pakistan?
Yes, we wear a common leishmaniasis, especially mountainous belt tops of the Sindh and Balochistan. There are 2 types of leishmaniasis, anthroponetic and zoonotic. But especially I saw anthroponetic leishmaniasis, especially Balochistan. We find HIV positive cases, they have the leishmaniasis. So they're the vector-borne disease. So how to treat if they're the HIV positive and leishmania positive and HIV positive? Drugs,
so it's
please. Drugs.
I don't know what available medications are being used in Pakistan for leishmaniasis, but you would probably use the same medicine, but we just have to see if there's a drug interaction with ARVs, but probably. Hold on, we'll see.
In Pakistan, meglutramine, glucantamine, name is the glucantamine, anti-money compounds are available, or the antifungal drugs we are using, diamino, diphenyl sulfone we are using, but especially anti-money compounds we are using injection form.
Okay. I mean, from what we can find, and this is available on the DHHS HIV guidelines of for opportunistic infections. So for visceral leishmaniasis, they recommend using conventional and lipid formulations of amphotericin B. They appear to be effective. Let's see, there's pentavalent antimony, which is also called sodium stibogluconate. But I'm not familiar if this medication would be available. And an additional option would be oral miltefosine. That again, I'm not familiar if it might be available.
Only these drugs will. Yeah. you say the availability of the drugs. Amphotericin B is not available in the, especially in Sindh and Balochistan. Only available in Islamabad, capital of the Pakistan. We have only anti-money compound drugs, especially injection form, but now they recommended fluconazole, WHO. They recommended fluconazole that you can use. But I use fluconazole to HIV positive cases of leishmaniasis. But they didn't response.
And how do you have a definitive diagnosis of leishmaniasis?
We are diagnosed by the LD bodies test and a biopsy.
By biopsy.
Bye-bye.
Okay. Okay. Because the one thing to think about is if it's not diagnosed by biopsy, sometimes patients can have other manifestations. But if it's biopsy, that should be accurate. But otherwise, adult HIV patients and pediatric can have a lot of other opportunistic infections, and sometimes and very often patients have more than one process going on. And so it's very important to, you know, keep a clinical idea of other things that could be going on, because often it may not be just one opportunistic infection, but you can have 2 or 3, especially when patients' CD4 counts are very low.
But I saw the clinical features of leishmaniasis in HIV positive case, just like a lepromatous leprosy. The nodular types patches throughout the body, like a neurofibroma.
Right, so that's why doing the biopsy would also be helpful instead of doing the antibodies.
We cut the nodule and see then under biopsy. We have no other investigation in Pakistan available. Only LD bodies and the biopsy.
Yeah. So they have to come up with infection disease and according to their protocol.
In most cases, it's okay to treat as you would without HIV infection as well, but just to be aware of the drug interactions.
No, I see. If there are no HIV positive, we can treat by the anti-money compounds and the fluconazole. They have the response, but in HIV positive, no response.
And the liposomal amphotericin is not available, or the regular amphotericin?
Only here, I say that only this drug is available, fluconazole and the anti-money compounds in our province, and the itraconazole is also antifungal. We are using sometimes. There are some research papers about itraconazole. But I say in HIV positive cases, they didn't response.
Right, so the issue with not only leishmaniasis, but also with other opportunistic infections with HIV is to, at the same time, be treating the HIV so that their immune system can slowly recover and they're able to clear the infections better, because if they're significantly immunocompromised and their HIV is not being treated, then definitely they will have a delayed response to the treatment of the opportunistic infections, in this case, the leishmaniasis. We can try to find more specific information about the use of fluconazole in leishmaniasis and forward it to you.
Yes. If we can do that, we can forward you more information about this.
Even we had done the biopsy, DNA test of the biopsy. So by our Japanese colleagues, so they say there's a positive zoonotic leishmaniasis. So we support from the Japan. But you know the problem is that many cases are not be response.
They're not responding at all to the fluconazole, or it's a delayed response?
There's a less response. There is some response. Only I say that 30%.
Yeah. And for how long? I mean, I'm just reading an article from the New England Journal recommending about 6 weeks of therapy with the fluconazole. For how long are the patients being treated there?
I gave the antifungal drugs, fluconazole up to 6 weeks, itraconazole 1 OD for the 21 days. If the megalucan antibody compound injection, I give the daily 1 injection, depends upon the per weight of the patient, up to the 20 days.
Okay. Yeah, we can try to find more specific information about other alternative treatments. But from what I'm seeing, it's the amphotericin seems to be more recommended for HIV, but we can try to find if the treatment duration or dosage is different for those that are HIV infected when we're using fluconazole, or if the stevogluconate might be preferred. But
Okay, madam. You can see. Okay, no, thank you very much.
I have a question. Are they're being used the mother-to-child transmission guidelines for pediatric HIV?
Oh, yes, there are the guidelines in department. If the mother is HIV positive, we treat with antiviral drugs to the mother. And once the newborn baby born, we put them on nevaparents for 6 weeks. And at 3 months, we do the viral load. And if it is positive, then we monitor and start treatment. If it is negative, then we stop. So there are the clear guidelines.
Yep, that sounds good. I was just in regard to the patient who had sepsis. So I think for that patient, it would really depend on, what the risk was with the, if the mom was treated or not in that situation. If her viral load was controlled, what the risk was of transmission for that child.
Dr. Sumro here. I will give a chance to Sindh Institute of Ophthalmology. Go ahead, please.
The question is, why not antiretroviral therapy can be given during anti-tuberculosis therapy? So the reason why we do not give both drugs at the same time is for several different reasons. One is because when you start antiretroviral therapy, you have soon you have a immune reconstitution. So your immune system starts to come back as your HIV viral load comes down. And so you can have a more significant response, adverse effects of having them start at the same time. One of the other reasons, which is probably makes even more sense, is that when you're starting 3 antiretroviral drugs and 4 new TB drugs and sometimes vitamins, it's very hard to manage all of that for the patient, and also to determine if there's side effects from the medicines. So for those 2 reasons, that's the main reason why you want to start TB therapy first and get it established and decrease the burden of active TB before you then start the HIV medicines. You want to give a chance for the TB to be killed for the first 2 weeks at least, 2 to 8 weeks, to decrease the burden of disease.
Hi, does anyone has any other questions?
Thank you very much. I'm Dr. Penwar from Saskatchewan. I'm really grateful for the speakers. They really devoted their precious time of the weekend, and the contents and the knowledge is really impressive and very much informative. I just emphasize my own point of view that in Sindh and in Pakistan, unfortunately, our health system is in very poor shape. So as a community worker, as the person from that part of world, we need to emphasize on the prevention of the diseases actually at the source. Like just we learned that hepatitis C is 10 times more infectious as compared to HIV, and the virus stay on needles more for many weeks. So unfortunately, in sin, still the needle stick injury is very common in the rural areas. People, our quakes and doctors are using the same syringes for more than more patients, and this poor health practices are prevalent. So we need to address that issue. Thank you very much. Thank you.
Yeah, thank you very much for joining, and we will have our final, last but not least webinar next Sunday. And I really thank you, Dr. Raibet and Dr. Sanchez. You guys came here on middle of your calls and on weekend. It's a great service. And for everyone in Pakistan, I just have the last few slides for some information. And now we have done all those important topics. So let us know if there is any need. Our last webinar will be on psychiatric issues, psychological help to families and patients. First of all, really, it gives a great satisfaction to see all our webinars are well attended and are creating waves in our healthcare landscape in Pakistan. Physicians are conducting seminars to address HIV/AIDS stigma in their patient communities. And thanks for Dr. Jumru, Dr. Sikandar Ali, and Dr. Farooq Somru for sharing your efforts information with us. If anyone else have any more pictures or your webinar information, please send it to us. And this is a picture, I just took it yesterday. I went to a market and I saw this in the middle of a big rest area. See, this is like kind of like disposal for syringes and everything, and it's everywhere in our markets, any restrooms, public areas. So I was just thinking we should start doing something more in the hospitals and at least clinics and wherever possible. So I just wanted to share this with you. Then we covered all those provider, patients, communications, everything. So next webinar is about psychological effects of HIV, and we will send the information again. And our acknowledgements, we have Providence Boston Center for AIDS Research and Brown University, Jinnah Sindh Medical University, Pakistan, Jinnah Sindh Medical Alumni Association of North America, and Apna Institute of Public Health, and everyone attending these conferences. So please send us email, let us know what you think. And pretty soon we will be sending the evaluation form to everyone. So please take a few minutes to fill them out. Thank you very much and have a good night.